Okay, so we're gonna be talking about a doctor, a patient, and a guideline committee walk into an exam room, the interplay between evidence-based medicine, guidelines, and shared decision-making. I'm Katie Baughman. I'm here at the University of Michigan as a neonatologist, also bioethicist. So I do some research within the bioethics world and research on shared decision-making regarding pediatric tracheostomies. With our title, we actually didn't come up with a punchline to the joke. So we just came up with more questions following it. We have no disclosures. So in this session, our main goal is that we're going to use examples from diverse medical specialties to explore and lead a discussion in the sometimes conflicting, sometimes synergistic relationship between clinical practice guidelines, the evidence that underlies those guidelines, and shared decision-making. So clinical practice guidelines are recommendations for clinical care about specific conditions that are based on relevant evidence. The CPGs are often created by medical societies. In my world, that would be the American Academy of Pediatrics or the AAP. American College of Gastroenterology is another one. Other guidelines are created by the US Preventive Services Task Force, which is an independent panel of experts in disease prevention and evidence-based medicine. There are some other guidelines that are created by government agencies like the CDC. Other guidelines that you may be familiar with are more local or institutional based. These are based on the evidence at those institutions, so it may be outcomes data, but we're not going to be focusing on those sorts of guidelines in this talk. The US Preventive Services Task Force has a nice report that they reference on their website regarding how to create CPGs. So clinical practice guidelines, there's not just one way to create them. The report that they reference is by the Institute of Medicine, and it's entitled Clinical Practice Guidelines We Can Trust. It has some valuable information on how CPGs may be created. The report stresses the importance that there's a guideline development group that's multidisciplinary. So this group should have experts in the field, should have relevant stakeholders, people that are impacted by the condition, and that may also include patients that are impacted by that condition. It's important that the people that are involved don't have conflicts of interest with the CPG, but that's really difficult to actually achieve in practice. It's then important that the groups conduct a comprehensive systematic review of the evidence for the CPG topic. So they should look at all of the relevant research so that it is based on the most up-to-date evidence. With the US Preventive Services Task Force, they do a rating system for their CPGs to have their recommendations rated based on certainty of benefit for the recommendation. Other societies use different ways of expressing how strongly they recommend the endpoint of their guideline. Finally, the guideline should be reviewed by stakeholders, and it should be updated in regular intervals, sooner if there's new evidence. There are benefits and limitations to guidelines. So one of the main benefits is that you're using relevant evidence for the guideline. So this means that there's a comprehensive review of the evidence and recommendations based on that. That would be really difficult for a clinician to look at every condition they're treating, all of the evidence, and come up with the best treatment plan. So it kind of standardizes that evidence so that you can apply it to a different condition. They lighten the burden by shifting that research to the experts who come up with these guidelines. Additionally, CPGs do standardize the approach for specific diseases or clinical scenarios. This allows for a more standardized and perhaps more equitable healthcare. They also improve consistency for disease management. So CPGs that are available nationwide, you're going to be having more consistency of the recommendations between centers. This may improve quality of care, but that's really difficult to actually measure. There are lots of limitations to guidelines too. So one limitation is the influence of the guideline committee. You are having experts in the fields that are impacting these guidelines, and they're going to come to the guideline with some bias. Although there's recommendations for no conflicts of interest, that actually doesn't always happen. The other limitation is also what I said as a benefit. So they are standardized. This means that they don't take into account individual patient circumstances. individual patient preferences, values. They utilize objective information to lead to recommendations, but missing from that are all the details that make the patient an individual person. So then we get into shared decision-making. This allows for individual care of a patient, incorporating their values. In shared decision-making, patients or families can vocalize their preference for recommendations, including how they want to receive the information, how they want to receive recommendations about treatment. Their values are going to be incorporated. Some CPGs do include recommendations that shared decision-making should be used, but this is often when the outcomes are less certain. So can clinical guidelines and shared decision-making coexist? CPGs provide recommendations based on evidence, but they're simply recommendations, they're not requirements. This gives clinicians the ability to individualize care and modify their counseling. Some CPGs, as I mentioned, do include shared decision-making as a recommendation when there's less certainty about outcomes. But there's tension between the goals of CPGs and the goals of shared decision-making. CPGs standardize care, whereas shared decision-making personalizes care. So that leads us to our questions for our talk. Can CPGs and shared decision-making coexist? Can one lead to the other? Is one preferable? And if so, is it preferable in all clinical cases? So to evaluate these questions and perhaps further complicate these questions, we're going to go over 3 clinical cases. The cases will focus on pancreatic cyst management, lung cancer screening, and vaccination recommendations.
Good morning, everyone. The last clinician crosstalk, they started by asking the audience for who the clinicians are in the room. So I found that very interesting. So if all the clinicians can please raise their hands. All right, about the same as last time. All right, so especially for the non-clinical people, I bet everyone's wondering what in the world I'm going to be doing up here talking about pancreatic cysts. So they're actually much more common than you think. Our best estimates are that about 800,000 people are diagnosed with a pancreatic cyst in the United States every year. And once you get older, over 60 and over 70, the prevalence of all comers is about 30%. So these are extremely common. And my clinic I'm sorry, I didn't introduce myself. I'm a surgical oncologist at NYU. I focus on liver and pancreas. And one of the things I treat is people with pancreas cancer, and pancreas cysts are a big part of what I do. But my clinic is often inundated with people that get these scans for some other reason, often in the emergency department, and they find a cyst in their pancreas, and they get sent to me to know what to do with it. And these cysts exist on a spectrum. The vast majority of them, you don't have to worry, are these low-grade cysts that'll never cause anyone a problem. But they are pre-malignant. They develop in this progression to high-grade cysts and then eventually to develop pancreas cancer. So when I see patients with pancreas cysts, the choice I have to make is whether or not to recommend surgery to take it out, along with part of the pancreas, or to do surveillance where we keep watching it with scans every year, and some people say every year for the rest of your life. The problem is these treatments are extremely consequential because pancreas surgery is a big deal. It's a major abdominal surgery. The good thing is it has the potential to prevent cancer. It certainly removes the cyst and prevents the cyst from developing cancer in the future. And to the extent that there's a small cancer in the cyst, it's a very effective treatment for that early stage cancer. The downside is that it's major abdominal surgery and there's significant risk involved. And even in very high volume centers where the best pancreas surgeons exist, there's a significant risk of complication, 40–50% chance of serious complication, and even a chance of death after surgery. And for some of the operations we do across the board, it's about a 1% chance that the patient dies after surgery. So it's not an innocuous treatment. The other treatment option is surveillance, and obviously with surveillance you avoid the upfront risk of surgery. But the downside is you potentially leave an early cancer untreated. And it's also a significant inconvenience for patients, especially patients that have these really small, low-risk cysts. They're undergoing scans every year. There's a significant source of inconvenience and anxiety. And so the crux of the decision is to figure out the optimal timing of treatment. And in a best case scenario, if we knew a cyst was low grade, we would say that a surgery would be too early. If it was cancer, it would be too late. And the sweet spot is removing a cyst and it turns out to be high grade. The problem is we don't know where the cyst is on the spectrum with any confidence until after we do a surgery and take it out and the pathologist looks at it under a microscope. So if you buy this idea that we brought up, that there's the spectrum between guidelines and shared decision-making, and for some reason, this is what Gemini thinks a shared decision-making guideline committee looks like. And this is what a shared decision-making looks like. If we buy that this is a spectrum from guidelines to shared decision-making, I would say pancreas cysts exist all the way to the old men smoking cigars end of the spectrum. So that's mostly how people make their treatment decisions. We rely on these international consensus guidelines that are notoriously weak. They're based on expert opinion at best. They're hardly even evidence-based guidelines. They're mostly expert opinion. The crux of it, if I can make a caricature of the guidelines, is if it looks a bit scary, take it out. And there's no mention whatsoever. Until more recently, there's like maybe one line in the guidelines about considering shared decision-making, but it's really just an afterthought of the guidelines. And what makes it worse is that these guidelines are not very good. We get it wrong. We end up with an incorrect diagnosis in over a third of cases where we take the cyst out and it's not even one of these pre-malignant cysts. And then we're too early almost 2/3 of the time. So clearly there's something wrong here and there's definitely an opportunity for improvement. And so despite the fact that we rely heavily on guidelines, I want to focus on two questions that really to me are fundamental to our treatment decisions that undermine the use of guidelines almost altogether. One is, what is the risk of cancer? Can we quantify what the risk of cancer is in the cyst? And secondly, even if we could quantify with perfection the likelihood that a cyst had cancer, what is our cancer risk threshold? At what level of cancer risk should we intervene with this major abdominal surgery? So I'll start with what's the risk of cancer in the cyst. These are data from a survey study of a group of international experts of pancreatic cysts from our specialty society, and given a standardized clinical vignette, we asked them what's the likelihood of cancer in the cyst. We showed them the images, the scan, all the clinical information that they would need to answer this question, and you can see here that they're all over the map. And this is important in and of itself because you go to two surgeons and you're going to get a completely different estimate of what the risk of cancer is. But even more important is that this very much drives their decision making. And you can see that those, does this have a pointer? I don't know. People who thought that the risk of cancer was low, below the median level, were significantly less likely to recommend surgery than those that thought that the risk of cancer was high. The second question is what level of cancer risk should prompt surgery? What is the cancer risk threshold? And as I go through, before I go through these slides, I'd encourage all of you, without all the information necessary, just the limited information that I've given you, just think to yourself, if you happen to end up in the emergency room today or tomorrow, you get a CT scan, you're found to have a pancreatic cyst, and you're told that there's a chance it may be cancer, at what level of cancer risk would you want to undergo a major abdominal surgery to take that cyst out and ease your mind that you don't have cancer, or if you do have cancer, it's effectively treated? So we effectively asked a group of surgeons that exact question, and this is what we found. We found, again, there was this very wide variation among surgeons on where they would set their risk threshold. It clustered around about 15%. But some people wanted it to be 50% or higher before they intervened and recommended surgery. We can also ask patients that, and that's what we did with a panel of healthy volunteers, several hundred people. And I'll point out here that for patients, the median level of cancer risk threshold was much higher, 25% over compared to 15% for the surgeons, and they varied even more. So going back to these two questions, then the reason I say that they undermine guidelines is because guidelines inherently can't possibly take these things into consideration. When you're making a population level recommendation, you can't possibly account for an individual cyst, what the likelihood of cancer is in it. And even if you do happen to get that right, on aggregate, if you can cluster into buckets of low risk 0 to 10% or something like that, you still can't answer the question of what is the optimal risk threshold for the individual or for the patient, not to mention the fact of what happens when those two thresholds conflict with one another and the patient has a lower risk threshold than the surgeon or vice versa. So they really are unable to address these complicated aspects of the decision at all. And so my take-home point as I hand it over is that I think there's plenty of opportunity to move the case of pancreatic cysts away from this boardroom of old white men smoking cigars and shift it much more towards these pleasant-looking people that are happy to do their jobs and talk to patients about shared decision-making. Thanks.
All right, I'm Josh Rager. I'm a general internist. I do adult primary care. I'm at Indiana University and a investigator in the Center for Health Services Research at Regenstrief. I'll be talking about this topic as it relates to lung cancer screening. So let's imagine, step into my shoes and what I know are the shoes of others in this room. You're this busy primary care doc. The evening before your next day of clinic, you scan your schedule. And this is what it looks like, right? Some follow-ups, some new patients. You have some slots that are walk-in visits because those bill higher. Your health system likes this. You scan that list, you see 3 of the 20 patients smoke and therefore may be eligible for lung cancer screening. You're reminded of this. There's been some recent advocacy work in your area. That's the only reason. There's this bus that's driving around and screening people. You just came back from vacation. You had a lovely vacation on the beach where you were able to catch up on your inbox finally, right? And so now you're actually thinking about the missing preventive care for your patients. Patient 1, this is a 6-year-old white female, smokes a half a pack a day for the last 40 years. History of bilateral knee osteoarthritis. Patient 2, 7-year-old black male, smokes 45 years at a pack per day. History of well-controlled COPD, high cholesterol, high blood pressure, some prostate issues, some non-obstructive coronary artery disease, on several meds, but doing quite well. Patient 3, this is a 50-year-old white male who smoked for about 20 years at a pack per day then, but he's quit about a decade ago now, has a history of high blood pressure, he's on a medicine, has obesity, he has diabetes, but this is also well controlled on metformin. You go to the guidelines. There's going to be a medical student with you tomorrow in clinic, so you wanted to review these things, make sure you're up to date. And you look at the task force recommendations and you see green, right? Green means go. This is awesome. Grade B, this is moderate certainty of moderate net benefit for adults aged 50 to 80 who have smoked 20 pack years and currently smoke or have quit within the past 15 years. You look further into the guideline, you realize this is based off of 2 randomized controlled trials, which showed a decrease in lung cancer-related mortality. The National Lung Screening Trial, that average relative risk reduction is about 20%. You look further into the practice considerations of the recommendation, and you see this recommendation for shared decision-making prior to undergoing lung cancer screening or making a decision about it. You're reminded that Medicare actually requires, as a condition of reimbursement, that a shared decision-making encounter occur and a patient decision aid is delivered. You look back over these patients and you say, oh boy, they're all eligible for lung cancer screening tomorrow. So shared decision-making for everyone, right? Everyone who's eligible. like I said, you're well rested. You've got your wits about you now. Your brain is kicking in again. You say, the smoking history and the overall profile is quite different of these patients. Doesn't that overwhelmingly determine their risk of lung cancer? Wouldn't that then impact their projected net benefit from lung cancer screening? And sure enough, you're right. You remembered things in medical school. And that as lung cancer risk increases, so too does net benefit. This is also written in the task force guidelines. But as it turns out, among those who are eligible for lung cancer screening, the variation in risk for lung cancer is tenfold. Very different groups of people. And so guidelines are created to be simple and implementable, right? And so it looks very dichotomous and black and white. Often there are eligibility criteria that are based off of the inclusion criteria of a randomized controlled trial. And so when shared decision-making gets applied to these recommendations, it also starts looking very dichotomous, above which you would do shared decision-making all the time for everyone, below which you don't get it ever. But the reality is that all patients who smoke exist on this spectrum of net benefit from lung cancer screening, from very low to very high, and to people in the middle, where it's a little more gray. There's a moderate chance of net benefit. And so you ask yourself, if this spectrum is the reality, wouldn't that change the individual recommendations I make and my overall approach to talking about lung cancer screening, engaging in shared decision-making about lung cancer screening? Right, for my patient with chronic lung disease, patient number 2, we didn't share in a decision about his pneumonia shot. Every fall when he comes, I tell him to take the flu vaccine. So what is the intuition that's underlying the reason why I feel okay with making a strong recommendation? Well, it's the balance between benefits and harm, which is the principle of medical practice. And then the degree to which you imagine preferences are going to impact that. And benefit really is the breakdown of an individual's risk without that intervention times that relative risk reduction of the intervention minus the harms. And this is what we get from evidence. Randomized controlled trial are just but one part of that. It's other observational research, other research using risk prediction, et cetera. And then preferences are what we get from patients. So in the case of the annual flu shot for your patient with chronic lung disease, however the preferences are, it's not going to change your initial recommendation and your projection of net benefit for that individual based off of this balance. We always respect patients' autonomy to make their own decisions. I don't hold patients down and give them vaccines, right? So they will ultimately choose to do what they want, and you should make that available, but that doesn't alter where you start. But there are these instances in which the decision is preference sensitive. And what we mean here is that we're scaling now in between net benefit and net harm. In lung cancer screening, you either get the low dose CT as of now or not. These are your options. So back to our patients, they're all eligible, but what is their risk? How will that impact the strength of my recommendation or action about lung cancer screening? So for patient number 1, their risk of lung cancer in the next 5 years, 1.2%. The number needed to screen to avoid one lung cancer death is 800. The rate of invasive procedures due to false positive is 13 to 17 per 1,000. And then of those people who undergo a procedure, there's one complication per 1,000. You have access, everyone actually has access to the tool that this is based off of, which is screenlc.com, which I highly recommend. I have no stake in it, but I like it. So what I think we're seeing here is like, you know, the trade-off in benefits and harms for this individual is really quite close. So how they feel about the screening test itself, right? This idea of false positives, potential need for follow-ups is very important. And it may take a longer conversation to feel these things out. But then there's patient number 2. His risk of lung cancer in the next 5 years is 9%. The number needed to screen to avoid one death is 57. His estimated life expectancy is greater than 11 years. This patient is on that far end of the encouraged spectrum, right? This looks more like a you should get a flu shot kind of decision. This doesn't mean the patient still couldn't do it, but I think where I start is, I think this is a good deal for you to undergo screening. There are these risks, they should still be informed of these risks, but the degree to which his preferences alter that decision or what my recommendation is very small. And then finally, patient 3, risk of lung cancer in the next 5 years is 0.14%. Number needed to screen, about 7,500. I don't know if in my lifetime I will be able to see enough patients like this to save a lung cancer death. So this patient is eligible for lung cancer screening. Their risk is very low. And here, because it's eligible, it's sort of falling in this preference-sensitive area. But I'd argue, I'm not even sure I would bring it up because it feels so low. So in summary, evidence-based medicine is more than just your randomized clinical trial. And shared decision-making is ultimately about personalizing care and decisions. When there's a lot of variation among patients and their risk for an outcome, these broad eligibility criteria can be insufficient to convey the guidance needed to make good patient-centered decisions. But often, primary care docs don't have the right tools to know and do this or the time. And the totality of evidence-based medicine can help us personalize care. And so when it is of high quality, this can actually lead us and help us to know for whom detailed shared decision-making is most essential and for whom not so much. And I think this is clinically intuitive, I'm going to say ethically defensible, and practical. Because what we're doing, I think, is doing this balance between these core principles of biomedical ethics: beneficence, autonomy, non-maleficence. And so to tie it back into the theme of the conference, I think this is principled practice and sort of vacillating between these things. So thanks.
Okay, Josh tried to steal my thunder with his one-liner anecdote about annual flu vaccination. But I'm gonna dig in here and really talk about the coexistence of guidelines and shared decision-making, and specifically embedding shared decision-making as a recommendation within guidelines. So my name is Cara Janusz. I am faculty at Wake Forest University School of Medicine, where I'm an assistant professor in the Department of Implementation Science and Pediatrics. And I've been thinking about this a lot lately for many reasons. I study immunization policy development and implementation, and really prior to the past few months have been thinking about how can we apply principles of shared decision-making to vaccine decisions. I have 2 disclosures that, in addition to the no financial conflicts of interest, just to mention, I'm not a clinician. And it's been a real pleasure to be a part of this crosstalk series to get the clinical perspective. I think over the course of the past 3 days, we've had many conversations in the research community about how we actually do this. And this has kind of afforded the opportunity to think about real-world considerations when talking about the integration of shared decision-making with evidence-based medicine. Secondly, we are all currently collectively living through, at least in the US, changes in the immunization policy environment daily. My talk is really gonna be based on the historical model, but open for conversation after we close our cases. So by way of background, I wanted to give a brief introduction to how evidence-based immunization guidance is developed in the US. As many of you will know, the Advisory Committee on Immunization Practices has been around for decades, established in 1964, supports the development of vaccine policy formulation in the capacity as a federally chartered advisory committee, providing expert external advice to the US Centers for Disease Control under the Department of Health and Human Services. The committee advises on the use of FDA-authorized vaccines in civilian population. The recommendations encompass adoption recommendations for FDA-approved biologicals, as well as contraindications, indications, definition of the target group, and even so much as implementation strategies. Importantly, also often defining a research agenda for post-marketing surveillance safety considerations. So since 2010, ACIP has used GRADE to assess and weigh harms and benefits for vaccines. Principal kind of consideration that underlies the recommendations, and most recently, or in recent years, CDC has also adopted an adapted version of GRADE's evidence to decision framework that really covers 8 decision domains, each with issue-specific decision criteria elements that are defined from the outset when taking up a new policy consideration within the committee. So ACIP work groups are charged with—
I think your slides are—
Thank you.
Yep.
Let's see.
There you go.
There we are. Sorry about that. I'm glad that you looked at those disclosure statements for a few seconds. Just to remind you that things are changing in the US. Back to the evidence to recommendation framework. So ACIP work groups, which are co-led by 2 ACIP members and substantive area experts from the CDC, really take on the work of organizing the evidence, synthesizing the quality of the evidence, and preparing these evidence to recommendation tables that over time are provided as updates to ACIP, and once the process is complete, or as comprehensive as is possible, a policy consideration is put on the agenda of the ACIP, and members publicly vote for policy options, of which there are 3. So ACIP can vote to not adopt a recommendation for use of vaccine intervention, can adopt a recommendation for use of the vaccine intervention, and more recently, there has been the inclusion of this third in-between tier on the basis of shared clinical decision-making. So the distinction between universally recommends and recommends on the basis of individual clinical decision-making used to be called category A and B recommendations, kind of similar to the classification that the US Preventive Services Task Force uses. And they were intended to, this category B was intended to allow providers and patients to jointly determine whether to pursue vaccination as opposed to making sweeping guidelines for an entire population, and language like individuals may be vaccinated was used. So in 2019, ACIP formally adopted the language of shared clinical decision-making, as we've seen has been a trend with other preventive guideline committees to officially adopt a tier of recommendations that explicitly call for shared decision-making in the process. So shared clinical decision-making recommendations as defined by ACIP are adopted primarily when use of a vaccine in a group or population level is unlikely to produce substantial population health benefits, but there may be individual benefit. Other considerations including lower favorability or confidence in the cost effectiveness of vaccination, which is driven often by population level burden, and net benefit would be taken into consideration. So importantly, ACIP does not prescribe a set of considerations or decision points for the patient provider to take into account in the process. And so this is defined and left at the discretion of the patient provider based on patient characteristics, values discussed during the encounter. There are important implications for financing to consider here. So while an FDA-approved product is technically available for use under the FDA indication, ACIP recommended vaccines are the only indications through which private and public insurers will reimburse. But this does include the shared clinical decision-making tier of recommendations. There are only a handful of recommendations on the schedule that use the shared clinical decision-making determination, and I'll talk about a few of these in just a second. So we have clear guidance on where shared clinical decision-making is indicated. Does that mean clarity for implementation? And I'm sure everyone in this room could quickly jump on that question. It's complicated, right? So most of the recommended immunization schedule features, like I said, universal routine vaccine recommendations. And for these vaccines, providers are encouraged to deliver strong age risk appropriate recommendations to vaccinate. Default is to recommend to vaccinate. And patients are encouraged to accept the decision to vaccinate as default. On the slide, I have the adult schedule. All yellow and purple coloring are routine universal recommendations, and the blue category recommendations are the shared clinical decision-making recommendations, which are left at the discretion of the patient provider to address. The same goes for the child and adolescent schedule, although there are fewer shared clinical decision-making type recommendations up until recently, where there has been a new shared clinical decision-making recommendation added outside of the routine ACIP procedures. So at the encounter level, health systems and providers are often guided by immunization forecasting tools programmed within the electronic health record to help with immunization delivery and counseling. But this often only applies to the routine universal recommendations, and providers and patients who are aware of the existence of the shared clinical decision-making recommendations are left to navigate the shared decision-making process on their own. CDC has in recent years published job aids for clinicians, but they focus much more on the indications of use, the dosing, the timing, once a provider and patient have arrived at the decision to proceed with vaccination under that shared clinical decision-making recommendation. So what else do we know about how this is going in practice? It's still a fairly new concept, as I said. This tier of recommendations has formally only been around since 2019, and there hasn't been a ton of work looking at the acceptability and reach of vaccine shared clinical decision-making style recommendations. But of the few survey-based studies that are published, there's consistent citing of issues with providers feeling unsure about how to interpret the shared clinical decision-making type recommendations and gaps in knowledge about insurance reimbursement for this recommendation type. Further, in the absence of guidance on when and how to apply shared clinical decision-making recommendations, some providers cite not using shared clinical decision-making and in its place, either not touching the conversation or outright recommending for or against in these specific populations. Interestingly, adult providers were in favor of the flexibility offered by shared clinical decision-making, but at the same time report that they have a perception that patients are confused by these recommendations. So it's not surprising that many of the themes we've been talking about over the past few days regarding shared clinical decision-making appear with this case. The literature is consistent. This slide doesn't really get at what I was planning on referring to, but there's two systematic reviews that look at decision aids and tools for supporting shared clinical decision-making around vaccines. And surprisingly, none of them touch on the actual recommendations that call for shared clinical decision-making. They're related to other vaccines, other age risk groups. So really, this is just a call to the research community that there's a huge opportunity to support the implementation of recommendations that call specifically for shared clinical decision-making. Another area that I would suggest is worth exploration is that while rare, there are some preference-sensitive decisions in the vaccine space. Most recently, the new RSV preventives. There's 2 products available with similar safety and efficacy profiles to that are risk-reducing for severe RSV disease in infants. And for a subset of pregnant women, they may equally have the option to choose to get vaccinated themselves or wait for their baby to get monoclonal antibody. No longer so relevant, but at one time there were many COVID products available with different technology platforms that could present a choice there. And then more broadly, just interest in thinking about how can we apply certain principles of shared decision-making to nuanced strategies for vaccine counseling, because there's a lot of need in that space. So just to wrap up here, Interventions targeting population health are different than many interventions that are targeting more individualized health outcomes, and they really do call for strong evidence-based policy formulation. Historically in the US, we have had the support of these systems in place. The effectiveness, acceptability, and usefulness of guidelines that recommend shared decision-making, as is becoming a trend, are reduced when accompanied by limited guidance to actually support patients and providers to engage in that process. And then finally, shared decision-making principles may be helpful in some situations with vaccines. So I haven't answered any of our questions, but hopefully giving you some food for thought. And I'm gonna pass it over to Dan, who's gonna do some more reflections.
Yeah, reflections indeed, I think is basically all I'm going to do. There will be no data in this talk. So I'm Dan Wiener. I'm a thoracic surgeon at the Brigham and Women's Hospital at the VA in Boston. It's been a real privilege getting to know the people on this panel. We've spent the last several months coming up with this title, discussing the approach topic, basically talking in circles. And I've really enjoyed our conversations and hearing everyone's perspectives. For those of you who don't old enough to remember the 1985 John Hughes movie, The Breakfast Club. I kind of feel like it was a little bit like that, where you have a brain, a jock, a princess, a basket case, and a criminal all come together, to form this close bond over this topic. I'm not going to say
who's the basket case.
No, I'm not going to say who's who in this analogy, but just leave it as that I'm grateful for the connections, and I look forward to more collaboration in the future. So I have no financial disclosures. I am a physician, not a PhD. I was a philosophy major. I am not really a researcher. I'm primarily a clinician, administrator, and educator. And I'm like the worst kind of clinician. I'm a thoracic surgeon, so we have a bad reputation in general. But in any event, as a relatively new member to the Society for Medical Decision Making, it's my understanding that at least one purpose of these crosstalks is to spend some time making some real-world observations about the principles and methodologies that have been so thoughtfully studied and presented in this meeting. So here you go. This is what shared decision-making and a guideline concordant care looks like in real world. This is at least what ChatGPT thinks it looks like. As you've heard over the last several minutes, we've heard about some of the nuances and complexities that arise when trying to deliver guideline concordant care while simultaneously participating in shared decision-making. In the case of pancreatic cysts, Greg discussed that while guidelines may be well suited for streamlining care, ultimately these treatment decisions are based on individual patient's probability of cancer and that individual patient's risk threshold, and that these risks and thresholds can vary from patient to patient. And shared decision making is really probably the right way to accommodate these individual differences. In the case of lung cancer screening, we heard Josh talk about evidence-based medicine not being a one-size-fits-all, particularly in the context of lung cancer screening, where broad categorization is insufficient when trying to guide physicians and patients toward a patient-centered decision. And providers don't always have the tools or the time to do this. High-quality evidence based medicine should be able to indicate when shared decision-making is most relevant and when it is not as important. And this becomes incredibly complicated when the guidelines themselves call for shared decision-making but don't explain how to do it. And as mentioned in Cara's example, in the context of vaccination, there's added complexity when we start talking about population health and not just individual health in isolation. And in this context, there's a need for strong evidence-based policy formulation and a clear articulation of recommendations to the public, with the emphasis on shared decision-making being more clearly articulated in terms of incorporating patient preference. So just a few thoughts and reflections, as mentioned, about shared decision-making. I think if we lean into the current climate of radical polarization, it's easy to present this topic as a tension that exists between two extremes. That said, I don't think anyone here would argue for care that is solely patient-driven. And on the flip side, I don't think any of us would want clinical care decisions to be completely devoid of patient preference and purely driven by guidelines. On the one hand, we have shared decision-making, and on the other, guideline-driven care. And when we talk about these concepts, we often talk about them as needing to find a balance between two alternatives that are in opposition to each other. And at extremes, we can perceive this as a tension that exists between autonomy and paternalism. But obviously, as we've learned over the course of this conference, shared decision-making is not simply the prioritization of patient preferences above all else, and evidence-based medicine and guideline concordant care are not, at least conceptually, intended to be enforceable mandates that must be applied without consideration of the clinical context. Though we've obviously heard about circumstances where guideline concordance becomes a metric for reimbursement and or performance incentivization. But I would propose that rather than a framework that requires balancing concepts or winning in a game of tug of war, perhaps we consider conceptualizing shared decision-making and evidence-based medicine as a compass and a map. Without evidence or guidelines, patients and providers would be left to their own devices, essentially bushwhacking, hiking through a morass or jungle of medical literature, trying to extrapolate data to the best of their abilities. And even if evidence existed and these guidelines provided these paths, without shared decision-making, providers would not be able to make recommendations regarding which path is better for patients to follow. So evidence-based medicine, in this sense, defines the topography, and the guidelines become the trails. And by engaging in shared decision-making, physicians help patients use their own compass to navigate these trails. Because even with trails, it's all too easy to get turned around and lose direction. And in some instances, there may be only one trail or two trails, and the compass or the shared decision-making isn't all that necessary. But when there are multiple paths, the compass or the map become more important. A path leading up a steep mountain, for example, may represent a guideline pointing towards surgical care in the case of maybe taking out your pancreas or your esophagus. There may be a flatter path that heads towards a lake that may represent a non-surgical option where prioritization is given to symptom management or quality of life. These guidelines and evidence have carved out the trails to get to these destinations, and the process of shared decision-making is the compass that help us navigate towards these paths or these goals. So I'm just going to skip over all these next slides and just say that ultimately what we want, right, our ultimate goal as clinicians and scientists researching this field is to come up with a way to use the best available evidence and incorporate the experience of the healthcare team and the patient values to come up with care that is high quality, high value, and personalized. And this requires the warm embrace, shall I say, of or synergy between shared decision-making and evidence-based medicine, rather than a gap that exists between them. With that, I will conclude. I will say I used ChatGPT to generate this image. And while this is incredibly scary in some ways to think about the fact that like none of these people really exist, I do like the picture in the sense that it shows that everyone is really working together on this and clearly happy with their outcome. And I'll also mention that I like the fact that the patient is not actually at the center of this picture, because while we do often talk about patient-centered care, I think there should be a subtle difference. I think that the center of care should really be this ideal quality decision and quality outcome. And putting the patient at the center of the care often can overemphasize, I think, their preferences at the expense of sort of a broader conceptual ideal. Anyway, I will end with that and open it up for discussions and questions. So.
Thank you. Francesca Williamson, University of Michigan. And one of the things that I'm curious about, having done some work in medical education, is how do trainees learn about shared decision-making? Do they learn how to do it, when to do it? Curious to hear your feedback on that.
Are these on? Can you hear me? Yeah. I think we should have the clinicians here talk about their training on the aspect, but there was at least in pediatrics, a great talk by a trainee the other day suggesting that there is very limited structured training on the topic, the exposure to that this exists, but actually how to do it, how to engage with tools that are available is not comprehensively taught.
So I lead the bioethics education for our pediatric residents, and I kind of clump shared decision-making in with my bioethics training. But when I meet with the residents, the first thing I ask them is, what training do you have in bioethics and these topics? And usually they'll say, like, I had a lecture, I had a couple lectures. A couple people actually did like a master's in bioethics or something, but usually it's not very much. So I don't think it's great, and it's not standardized at all with what's taught. I think the best training that people get when it comes to shared decision-making is actually what they see in practice and what they take from other people.
I will say, recently, for those clinicians in the room, we do have these like continuing medical education requirements at the hospital every year. You have to take Health Stream or whatever it's called, and we recently did actually have one on sort of shared decision making, and it was examples of a patient-provider interview. So it does exist even for clinicians beyond medical school, but it is not part of like a main part of the curriculum.
I think another challenge with it is that shared decision making has become a catchphrase.
Yeah.
And there's a lot of social bias to do shared decision making, but as people are saying, not great or sometimes any formal education. So I think people think they're doing it. Sorry, I'm Ellen Lipstein, Cincinnati Children's and general pediatrician, and all the time, residents come out, they've been in a room for like 6.2 seconds, and they're like, we made a shared decision making about X, Y, Z. I'm like, first of all, that wasn't something to like share a decision about to the point of this, right? Like, how we're gonna treat your viral infection is not really a place for shared decision making. But also they have no conception of what they mean when they say that. And so I think it's incumbent upon those of us who do have a framework to push back to both our trainees and our colleagues about what do you mean when you say that and how are you actually sharing decisions.
I'll just add to that it's also very specialty specific, because as I can imagine in pediatrics and probably internal medicine and primary care, it is a buzzword in a vast majority of the surgical fields. It's not even a concept that anyone's even heard about before. So it's far from becoming like just jargon in those fields. And then just back to the question on training, I got no training whatsoever in shared decision making. I'm clearly an advocate for shared decision making, and I have no idea how to train other people on how to do it.
Really fascinating presentations. This is a problem I've been thinking about too, but guidelines are, of course, as you all said, guidelines. So how do we have fuzzy exceptions to the guidelines that are not chaos? In other words, there are always going to be exceptions that in fact are justifiable, make sense ethically, maybe have to do with the autonomy of the patient, or just are plain common sense, but don't fit the guideline literally. How do we have policy around that makes that a possibility?
Well, this may be off topic, a little bit tangentially related. In the world of thoracic surgery, for example, we have guidelines that were measured on in terms of quality outcome about how many lymph nodes we take out at the time of a curative intent lung resection. The expectation is that you meet this guideline or metric 80% of the time, with the understanding that 20% of the time there may be some exceptions. So I think it may be that's the concept, is that you sort of set a threshold of expected guideline concordant care. I don't know if that answers it, though.
Yeah, I also am of the opinion, I think this is, one of the, because it is such an issue, it should make us reflect and think more about what is the overhaul to the guideline process that can help us do this better. And it does get messy because, right, when you see this A, B recommendation, it's gonna get covered by insurance as of now. pending, current trials. Court trials, right? Court cases. And so like I am of the opinion, if you wanted to do that, you would have to rethink this entire enterprise, which is also a burden and a problem. But I think it comes from both the top, right? But also we're also identifying that through our medical training, through our education, we're all missing out on this. And really, I think shared decision-making, when it is done at its best, it is the combination of the best available evidence and then marrying that with patient preference. That is clinical medicine, right? Like at its highest. And so like the fact that we aren't aiming for that in our education and didactics is like a little alarming, yeah. And the context, yes, yeah.
My name is Clayton Hicks. I'm a medical student at Indiana, and I really appreciate at the end that you show this balanced scale of paternalism and autonomy. Like in my experience in education, it's been presented as medicine used to be paternalism, and now it's shared decision making. And it seems like in my class, what that sounds like is, so that means we should give all of the information possible and kind of spit as much as possible at the patient so that they can make their own decision based off their preferences. And it's a complete split, like none of it's shared. We're a vending machine to tell people information, and then you make your decision based off only your autonomy. And I think there's just it was already mentioned, but like it's a word that's just thrown out that I think is completely misunderstood by the vast majority of people in my class. And again, some of it might come up more in clinical training and rotations and residency, but when your understanding of shared decision-making is to have the patient be the full decider and you have no nudging or no anything like that, I think it completely separates the role of all of the training and background and understanding of the evidence. That how do you expect a patient to understand the evidence when it's hard for clinicians to understand it themselves?
Yeah, I'll say, I think that's a great point. And in real world application, I can think of these examples. I don't know if you guys have seen it, like giving a patient or a family ultimate autonomy in like a DNR discussion, right? It's sort of like, okay, you have to choose if you want to be full code or not. And then within that, okay, do you want to be intubated? Do you want chest compressions? Do you want pressors? Do you want, antibiotics? And now it's like overwhelming, right? When you give all of this information and say, now you choose, right? And that really is not shared decision-making. That's sort of like just giving complete autonomy. And that's, I think, suboptimal care. Yeah.
In some ways, too, that shifts the burden onto the patient or family, especially with decisions like that. It is putting that all on them. And for some families, that might be what they want, that they want to make that decision without much input. But it's important then to elicit what they want. Do they want a medical recommendation? How involved in the decision do they want to be? And so you don't want to be completely on one extreme all the time. But for some patients, they might want to lean more towards one extreme.
Yeah, and I mean, there are clearly people in this room that are far more experts in shared decision-making than I am, but my understanding of shared decision-making is not that, the way you described it. That like buffet style, like here are your options, go pick, and I think that's obfuscating the word shared. There's nothing shared about that, right? I think that shared decision-making, when done well, is guided conversation that includes the preferences, but there's no reason that a clinician can't still make a recommendation in the process of shared decision-making, especially if that's a recommendation that is aligned with the preferences that they've elicited.
Yeah, and arguably it's kind of the duty of the physician to make that recommendation when it's very clear that something is going to benefit the patient.
And I think Josh mentioned this in his talk, like patients can always refuse, right? Like that's autonomy, right? You can say, I recommend this is, I think this would benefit you. And if they say no, that's right after having this informed discussion, that's okay. They can't always request things, right? That's a different.
And we didn't dive deep into pediatric cases, but that statement is a little different once you get into peds, that they can't, they can't refuse necessarily.
Sorry. That's very adult-centric of me.
Yes.
Sorry.
We did that on purpose because it is a different topic in ways.
Hi, Alan Schwartz at UIC. I just want to call out Val's comment about context because that's a lot of what I study, that, it's not all about preferences, right? Sometimes everybody has the same preference, everybody would like the same thing, but the patient can't afford the better inhaler, they're getting their meds stolen from their mailbox, they can't get to the clinic, they can no longer see to dose their insulin correctly. Like, there's a lot of patient life context that I think gets in the way of some of these decisions, and also can only be addressed when physicians and patients are talking and listening to one another, so that the physician understands, we all agree we want to do something about your asthma, you want to take this, we can't do what the guideline would usually say because of the systems around your life, but here's how we could work around that, or here's something we could do that will work in your context and will improve your health the way we both want to. And I wonder if, you've talked a lot, I think, and very wisely about the incorporation of patient preferences, but how you think about the incorporation of life context.
Would you say that contextualizing care and shared decision-making, those feel very different to me personally? Because, right, there are these things like, I can't afford my insulin. Thank you for telling me, right? Like, and also this, I think there is this tendency often to say shared decision-making is talking to the patient. Yeah? That's sort of my impression. And so I think of the added advantage of shared decision-making, and there is that I do need to understand the context for sure, right? And that may alter my decisions, but I don't know if it impacts my shared decision-making. What do you think of that?
I mean, I guess I don't know. We think of preferences as a subset of context. So if you're not asking about why the patient isn't coming to their appointments, right, you'll never know whether there's a preference underlying this decision. You won't be able to make a shared decision.
Preference turns out to be an odd euphemism for actually like having it's not autonomy. They actually have a totally different choice set than you think they have.
Yeah.
You think they have this choice set. Their world is this choice set. To frame that as a preference is to deny their actual lived experience.
What I'm saying is I do not think, I think those are very important questions. I don't think of them as preferences, right?
Right.
Yeah, but
Yeah.
that was all that was
But
the
the shared decision making just preferences is what it is I'm asking.
Is shared decision making just preferences?
That's what was on the slide.
I'm going to say yes.
I just want to speak to this really quickly because the Agency for Healthcare Research and Quality has recently so they had a clinician shared decision-making training program that was very wonky, and we worked on improving it for a little while. And one of the things that they wanted us to do to improve it was to expand the definition of shared decision-making to address multiple comorbidities and also contextual factors in a person's life that would change what might be available or appropriate to the person, and to incorporate that into the shared decision-making conversation. So I wanted to just clarify that, like, people are thinking about this, and they have also written a bit about this, and so have we. But yeah, it's an active area of thinking and education.
Do folks want to weigh in on that? Do they feel like contextualizing care is a part of shared decision-making or is separate?
Oh, sorry, go ahead. Yeah.
I was going to say, I came to this actually because the paradigm in vaccine counseling is this presumptive approach where you announce that a vaccine is due. And there certainly may be different choice sets or framings that a family has that's worth discussing before announcing that this is the default. It's a little tricky in the environment right now, I think, to be talking that way. But certainly there's other constraints that might be present in terms of supply. In theory, there would have been a choice between the maternal vaccine against RSV and the monoclonal antibody, but the first year there wasn't supply for the monoclonal antibody, so by default, the only option was one, so it was the duty of the provider to, communicate that. I guess that's my comment on context there, but.
I would just add, and I think I'm probably misunderstanding all of it, but I work at the VA, where a lot of a lot of care is impacted by the context of the patients not being able to get a ride, not being able to get down for their PET scans or whatever other sort of circumstances, and I think the VA in particular does an excellent job of trying to incorporate, there's one response to that, which is like, well, how do we accommodate whatever context is preventing you from being able to get the guideline concordant care, but there's also sort of flexing the guidelines or the care that's being delivered to accommodate the context, right? And I think, I don't know, this is an interesting thing to think about. I really appreciate the question. Yeah. Yeah, the whole health model, and yeah.
Hi, I'm Peter Schwartz. I also am a clinician in a social safety net hospital. So I think you guys have, the discussion and the panelists have put their fingers on something very central, which is sometimes the concept of decision can expand to include everything, because we like to think of things as decisions. When, as you said here, often my patient unable to get her LAMA is because her inhaler, because it's insurance and it's income. And so we can see that as a case of shared decision making for me to understand the limitation from the pharmacy and talk to her about how to move forward. That's appropriate, but also it's appropriate to frame it as an access and health system problem to get this, guideline indicated inhaler into the hands of people who don't have certain resources. So I think the cusp of the question of like guidelines versus shared decision making, this does help sort of expand that concept here through this discussion about the limitations so many of our patients face and the way in which our system is so broken. Again, if you bring clinicians into this discussion, we'll tell you, as the policy people know also, maybe we all know, a broken system, and using the concept of decision within that can feel like we're missing something, unless the notion of decision became so broad as to be almost useless.
I mean, just to add to that, part of my practice is at Bellevue, a big safety net hospital. I am very familiar with the limitations of resource-limited setting and patients with limited resources. But I guess I'm tempted to agree with Josh on this, that preferences exist outside of it a little bit in two ways. One, I think that the context is important in that we're talking about a decision that has to be made, a choice between two things. Context can limit the ability to even have that choice. There may not even be a decision to make because my patient can't come into the hospital for a week because I've had this. They didn't want to leave their car on the street and get a parking ticket. I have a pancreas cancer patient have that. They can't leave their family at home. They can't leave their kids at home. So there is no choice there, right? So I think as a starting point, we're talking about a situation where there is a choice that can be made and both options are theoretically available. And the second thing is that I think that context obviously has to, just like all other lived experience, inform people's preferences. So I think of it as being related in that way, as like one informing the other, but them still kind of being separate issues.
Just a very quick question. So in one of the presentations mentioned about the guidelines, like the current guidelines are unable to address the risk of cancer and also the cancer risk threshold. So is that this problem specific to pancreatic cancer or can be generalized to other cancer like prostate cancer and breast cancer guidelines?
Yeah, I mean, I definitely think it's not specific to pancreas cancer. I think there's any other, we've been talking about lung nodules. Any pre-malignant lesion, in my mind, has, or even some cancers that are not necessarily as aggressive. So prostate cancer is a good example. Thyroid cancer is another good example. At least this framework of thinking about it, in my mind, applies to all pre-malignant lesions.
So I think we have about 4 minutes left. If folks have a final question or comment. Over here, yes. And it has to be a very, very good one because it is the last one.
Don't worry. Thanks, Josh.
No pressure.
No pressure. Katie Valentine, Mass General. So my question is about bringing guidelines and shared decision-making together more, kind of off what you said earlier, Josh, as well as what you said, Daniel. What do you guys think about bringing preferences as evidence into the guideline creation themselves so that the evidence that we look at is not solely based on clinical outcomes, but on patients' preferences towards these options as well before the guidelines come out themselves?
I can say in the vaccine space, it's tried to be explicitly included in the process, but where's the data? Like to do that, the ACIP historically has actually had a patient consumer advocate on the committee. How to fill that position, that profile, that training is challenging. There's been often someone with a legal background or a true patient advocate perspective. In the evidence recommendation framework that ACIP uses, there is an explicit domain for acceptability, which isn't exactly what you're talking about, but there's an intent to include patient preferences, but again, the data just isn't available.
I think my impression is that guideline committees will be ill-equipped to handle that kind of evidence. Depends on the guideline committee, but I think there is certain culture in each committee group. I think we're sort of talking about that difference in the international surgical guideline committees and maybe what I'm maybe a little bit more used to, and then grade and whatnot. But there's no like a procedure as well defined for a guideline committee to go through and sort of understand, right? Like, I don't even think they could understand, like, what is the quality of evidence behind that research that identifies these patient preferences? How can we then incorporate that into what we know about the randomized controlled trial, other observational research, growing like safety and efficacy data? That combination of things, which is what guideline groups do, is synthesize things. I don't think that kind of evidence and data they would know what to do with, and I don't think there's a process for understanding it.
So it sounds like there's an opening for us to create that process.
Theoretically, and at risk of being provocative, I would say it's not possible. I don't think there's a level of evidence that we could come up with that can measure patient preference, that could reach the standard that it would need to make a huge generalization across the population. And two, anytime you do that, it's the same thing as like the cancer risk threshold, right? The best case scenario is like, I don't know this very well, so forgive me, but statins, right? They come up with the threshold of what your risk of a heart attack is in X amount of time, and above that, you should take a statin, and below that, you shouldn't. And that's clearly a continuous variable, and they've picked an arbitrary point. So the same thing will inevitably happen with the preference, which is probably even more varied and more of a spectrum, and coming up with an inflection point on where you bucket people on one side or the other, or in three buckets, it just seems very messy to me. But maybe it's my lack of imagination.
I've literally written 2 papers on that.
All right, thank you all.
And I regret picking statins for myself.
So it is noon. Thanks all for your attendance and sticking with us. Yes, sticking with us till the end.